Well, it's always an honor to be here working with Datum to provide some CE and to just really get together with my good friend and colleague, Dr. Puterman. This is a topic that we have sort of expanded on in the last year or two, because it's really the heart of everything that we do. Everybody wants to minimize complications and to make things predictable. And so I know probably most people are here because they want to know how to make sure that they have enough bone, right? They do bone grafting, they're putting the patients through surgery, and they want to really have very good predictable results. But when we start talking about complications to our students that come to our course, it's really more about total care, and there's a lot of things that can go wrong. And we're going to start and give you guys some little tips that we use in our everyday practice, and hopefully you'll learn from our experiences so you don't have some of the complications that we've had in our practices, because we could have a seminar alone just on some of the worst days in our own practices. Israel.
Yeah, so looking at this pyramid over here, you can see that there are, complications really range from a whole lot of things. They go from the minimal complications, which really are not complications. They're just postoperative sequelae. And those are pain, swelling, bruising, bleeding. And those are things that we normally give medications for. And we give medications because we expect them. But what we're going to do today is show maybe advanced cases of those. And then also some other cases of bone graft shrinkage. Do we always get 100% of what we want? No, it's impossible. There's no way. That's an Instagram world. That's not real world. As much as we like to think that Instagram is real, most of the time, everybody, you see the best cases that we have. There are aesthetic failures. There's flap dehiscences, necroses. You're going to see our cases of these. These are not pie in the sky what ifs. These are our actual cases. Thankfully, we don't have anything up at the top, but we're going to at least talk about those subjects.
And I thought this was just a great place for us to start because, everybody knows and respects Israel for the work that he does. But I think you really have to appreciate when I asked him for cases for this webinar, this is the first thing he sent me. And it's pretty amazing because this is real life. So I'll let Israel talk you through this.
So you always know going around these prominent teeth, you go very, very slowly with your 15C blade. And it's a 15C, not a 15, but you go very, very slowly. And then, well, what happened there? And you look back and what do? You just go right back to it. You say, okay, there's not really anything that you can do with that. It's obviously a flap dehiscence because of an iatrogenic issue here, but you just go right to it. You can notice that I didn't pause, I didn't hesitate, I didn't throw things across the room. I just went right to making it work for me. And you could even see later on in the surgery, opened up the flap even more and use it as a vertical. Is it an ideal vertical? Heck no, it's not an ideal vertical, but you make the best of it. And when was that case done? That case was actually in residency. So that goes back about 12, 13 years now. And
it's interesting, Israel, because this is the type of case I've seen you do 100 times. And I can tell by looking at it what your incision design was going to be, right? You were going to do your typical
it hasn't changed
in the front. Right, your circular incision in the front, and then you were going to do your little vertical release in the distal if you need to. Right. And so we all talk about verticals and obviously not wanting them in aesthetic areas, but the gums don't scar. So, he went with the punches. He knew he needed to get access to the defect, and he couldn't go and raise that midline papilla now because he'll lose that papilla. So I think you recovered well. I'm sure this case, even in your immaturity being a resident, I'm sure you handled it, appropriately.
Yeah, there's no question. And I'm still immature, so there's that.
Here we go.
Yeah.
And this is a case that I just wanted to start because some of the worst days of my life have been little mistakes like this. And Israel's going to show you one of his cases. But as periodontists, we see this all the time. Obviously, we don't get referred healthy teeth to extract. Most of the teeth we extract are teeth that have recurrent decay, bridge work, and we're always trying to save teeth because patients don't want to lose the whole bridge. So this is a case where, you may decide to start sectioning the tooth, and there's a lot of things that can go wrong.
So this is a case of mine, and again, back in residency. But this is a case where I was doing my first full arch treatment. This is a mandibular all-on 6 case where I was extracting teeth, putting 6 implants, and immediate load. This was my first one back in residency. And I was very excited for it. We had in the anesthesiologist. I was not doing sedation on my own at that time. The anesthesiologist comes in, sedates the patient. I'm sectioning a bridge. Oops, passed the throat pack, went down, and we had to wake her up and say, not a single thing was done today, but you got to go to radiology and get an x-ray, get an abdominal chest x-ray. And that's not a fun day at all. And so I keep this x-ray very close and dear to my heart because it's humbling, and it's something like that that can hopefully guide you through a career.
Yeah, absolutely. And we've all been there. And hopefully we learn our lessons from it. And so this page, while not very, fancy, really is so critical. Okay. Because I didn't even know about a sweetheart till a couple of years ago. But if you ever nick a patient, the lingual of a patient's tongue, the sublingual area, and you start to see it swell, you understand, there is a better way. There's a safer way. And, you can use a sweetheart. You always need to have good retraction. The glasses are so important. I think everybody's seen that article that circulated on the internet a couple of years ago about something that dropped in the patient's eye at a dental office. And all of a sudden you're putting all this bacteria and really bad things can happen. So before you do anything, make yourself comfortable and take care of all of these things. You always need to have a throat pack. A C-sponge is a great idea for, a lot of the teeth we're doing that we're bone grafting, we're extracting teeth. And like I said, these are teeth that are not healthy. They're prone to fracture. Their crowns are prone to be, to pop off. And so you have to be very, very careful. Do you use a C-sponge, Israel? What do you use to throat pack?
We do have the C-sponges. We went through a phase where we were using them a lot and stopped. But every time I think about it, I want to get back into it. And we do use a throat pack with a sweetheart most often.
Yeah, and I think the bite block is important too, because patients just get tired. They get tired and they're comfortable. Some of them will tell you that they don't like it because maybe they've had it before and it was too big. But if you get the right size for the patient, usually they're way more comfortable and they'll be a lot easier to work on. So Israel went ahead and told you one of his worst days. I'll tell you one of my worst days. I was doing an anterior implant, flapless, very simple case. And the patient was an elderly gentleman. He was probably about 75. And I decided at the last minute that I want to make this perfect and I'm going to take a little bit of a soft tissue graft from the palate. And I went ahead and did that without an issue. I was doing the single incision technique at this point. So I was going a little bit deeper than what I'm doing now with the de-epithelialized graft. But it was pretty uneventful, but we delivered a partial, a flipper. And, I like to use that sort of like an obturator to put a lot of pressure on the palate. And I said to him, just leave it in for a couple of days, leave it in for 48 hours, come see me in 2 days, and I'm going to take it out in the office. Sure enough, everything went great. Patient went home, called me at about 11:30 at night, and he said he's bleeding. And so as a periodontist, I give my patients my phone number, mostly because I know they're not going to call. There's very few things, reasons why they're going to call me. And if they're going to call me, I'd rather, if they're having an issue, I'd rather them call me. And he called me and I asked him to send me a picture, of the area. And I was expecting to see a little bit of gauze with a little bit of blood. And he basically sent me a picture of his bathroom sink full of blood. And so, that type of situation can happen. You got to remember, we're dealing with anatomy. We're dealing with patients who are, either sick for other reasons, medically compromised, but also we're just working next to some vital parts of the human body that we need to respect. And so tissue grafting is fundamental, even though this is really a bone grafting and implant complications lecture. A lot of the time we're doing this simultaneously. So if you're going to play in this world, you really need to understand that there are risks and you need to know how to manage them. And this was another case that was referred to me by a buddy. And it looks like there's definitely a pretty moderate defect here, but obviously without a CT scan, we can't identify it. So the patient was put on my schedule and we have a CT scan at the office. I don't know why it wasn't taken before the patient was sent to me. But this was the CT scan, right? So I think a lot of you were thinking to yourself, wow, this is incredible. How many of us would have gotten burned on this case where we flap it open and we place our implant and where are you, right? You're in one of the worst places you can possibly be in the mouth. And
it's
happened
important to note. Sorry, Matt. I was just going to say it's important to note over here the ridge itself. A lot of people, you'd feel the ridge and you'd say, wow, that feels like a nice
Right.
thick ridge. So therefore, no problem. You don't need a CT scan. Frankly, as I go on in my career, I absolutely refuse to put a drill into a patient's mouth without a CT scan. I
Yeah,
won't do it.
and we've all gotten there because
Yeah.
this sort of thing is something that probably happened a lot more, often before we had CT scans. And we've all seen those cases of a maxillary anterior tooth where the implants, dehiscing through the vestibule. But that's not a safety issue. Some patients will be very uncomfortable. It's technically a failure, but it's not a catastrophic failure. The lingual sublingual arteries are in this area. So all periodontists know if you've ever seen the back end of a Pritchard elevator of a periodontist, you'll see it's all scuffed up, and that's because it's protecting the soft tissue. And so you need to be in there protecting the soft tissue, or doing guided surgery. And you need to be able to plan this out because there's a solution. We can place a smaller implant, right? We can place a narrower implant. We can place a shorter implant. We know that has a high success rate, but just don't be that person that has to call, the emergency, ambulance in the middle of a surgery, because those are situations you can't really come back from. Otherwise, we see bleeding all the time. We're expecting to see bleeding in surgery. That tells us our patients are alive. So it's not an issue, but there are certain areas of the mouth that you're going to have more bleeding than others. We talked about a couple already. Greater palatine, sometimes it's in the way. This was a case where I had to extract tooth number 9. And there was a vertical defect. I flap it open and I could see, and I knew beforehand because of the CT that there was a pretty large defect. Usually this type of thing can be managed with, 1 in 50 epi. So I know Israel regularly uses it as well.
Yeah, it's the first line of defense to bleeding. That's how I look at it.
Absolutely. And you can see if we manage the bleeding, in this case, I enucleated the whole cavity, and we grafted with our typical Ostix Plus protocol. Don't worry too much about primary closure, but it was a relatively large defect, and you can see we got great healing, and this type of bleeding is something that we expect to see day in and day out in our practices. This is another major cause of bleeding during surgery, right? These periosteal releasing incisions, and this is really what we love teaching in our course because it's very hard to visualize doing this through pictures and photos, right? It's really a hands-on exercise. But one thing to consider, there's a reason why we like to do this earlier in the surgery, because it causes bleeding. So you can see this beautiful photo on the left where I did the periosteal releasing much earlier in the surgery, and versus towards the end, where now all of a sudden we have to worry about putting pressure on the site to avoid possible hematoma formation. It makes it very difficult to adapt the materials, the biologic materials. And so, keeping the materials in place is going to be critical, and timing of those incisions is definitely something that you want to keep in mind. This was pretty interesting because a couple months ago, me and Israel had a meeting at about 5 o'clock at night that we were scheduled to be a part of. And so around 3:30, I texted him and I said, "How's your day going?" This was the picture he sends me back. So I decided I wouldn't bother him, and he later told me the story. So you can take a look here.
So this is a case where it's actually not that case, but we're going to get back to that case. This is one where you can see just a normal ridge augmentation, obviously a vertical component. But this is a situation where you don't really anticipate just a ton of bleeding. You just always have to be prepared for it. And you can see this is after I added 1 in 50K epi. It wasn't stopping. So the next line of defense that I have is this hemostatic collagen fibers that you can put into the site. This one is called blood stop. It's funny, we talk about this in the course, but blood stop is one of these things that I can't ask for it because the patients would freak out if you say, "Hey, pass me some of that blood stop that we have." And then we said, "Okay, well, how would blood be it?" And so just called it B-stop. And you get some weird looks of what is B-stop, but it is what it is. And you can see over here where I'm packing in multiple strips of it, and really was not getting a whole lot of bleeding control. It still kept coming. And so you just keep packing and packing away. And the key is just to be calm during these situations. You really have to just follow your own protocol, have a series of steps that you're going to be doing. How many of these do you have to place? You don't know. So it doesn't mean that you have one little container of it. You have to have enough of it to be able to have for this patient and future patients. So if you
So this
use
is a
them all,
resorbable type of sponge that you put in there.
it's resorbable. Yeah.
Yeah.
And it gels. And then this is a different case. This is the case that that I did text Matt about. And you could see that I went through blood stop. You could see in the bottom right, I went through Avitine. That's some leftover Avitine, which is very, very costly hemostatic microfibrillar collagen. And that works really, really well. But like I said, it's very expensive. And with this case, you never know when these things are going to happen. So, you know, how many times you're doing a free gingival graft and you think that you're going to have something go wrong at the recipient site. Donor site, you can expect it, not quite like this, but believe it or not, this came from the recipient site of an FGG. And it came as I was 95% done with the FGG. I had placed it in the number 31 area, and this was an edentulous site. And then as I was just releasing the last little bit of the flap it was kind of covering the graft a little bit, I released it, must have nicked some accessory artery, and the blood just wouldn't stop. It just kept coming.
I was wondering about this photo because I saw the barricade. So the barricade was going to be for the
donor site.
For the donor site. So the barricade has nothing to do with it. That's crazy.
Yeah.
You know, one thing to keep in mind, like in the first case that you showed, you know, you were so high up into the basal bone, you know,
yeah,
and you're getting very close to the larger vasculature. So it makes sense. But a lot of times we take out these teeth with these tremendous infections. And the second you take the teeth out, you start to see that flow. And it's almost like once you get it clean. I remember being in perio and cleaning teeth. And, you know, I'd say to my professor, you know, it's bleeding. He says, that's just, it's not clean yet. Right. So when you get it clean, that's when usually it'll stop bleeding. Obviously, you were closer to a larger vessel in that case.
Yeah.
This is something that I find, you know.
No, I was going to say, on that case, the only way that I got it to stop is really by pressure right over here, right at the facial artery, just pressing right here in the notch. And that's the only way that it would stop. Every time I removed my finger, it would start to pump blood. Very cool.
Yeah. Well, this is, you know, something that unfortunately we have to deal with every day. So I love the idea of having this, you know, go-to of materials and a protocol, you know, to use in these cases. A lot of times we'll do blind suturing. I've heard of people using bone wax. You know, sometimes you'll be doing these large all-on-4 cases and you start tabling the bone and you'll see a vessel. And so you could shoot anesthetic right into there. There's a lot of things you can do. I was advised by one of my buddies, he's an oral surgeon, to get an electrocautery device. And for me, I felt like to buy, you know, a huge unit for something that I'll probably use once a year at best was a little silly. I've been using this disposable Bovie pen. It's like $80 or something. And I had it for about 5 years. I used it on that patient we talked about where I went into the office and met him and I ended up cauterizing it. But this is super cool to have. And I bought another one since then. And I've had it, you know, again, it just sits in my tool chest. You know, if I ever need it, I have it. So,
and all of that is really to avoid having to fill it up all the way to the top. You want to stay down at the bottom here.
All right. Well, this is a good time then for you to have another drink before you talk about this case here.
So this is another one of mine who came in for extraction and ridge augmentation, lower left area. And this is, like Matt said, everything's going normal according to protocol. Place my O6 plus and doing a nice GBR over here. And then after I placed the sutures, I felt like I didn't get enough release of the flap. So I was releasing a little bit more. And if you don't get enough release early on, you have to do more, except this is the risk of what can happen. If you noticed, I perforated the tissue, the buccal flap over there. And I noticed it and I had to keep on going, but then perforated a second place. So at that point, really decide, okay, let's cut bait over here and remove these sutures, and just going to have to release much more apically and forget that initial release. So That's what I was doing over here. You just go much deeper, and you kind of let, like you have a sinus perforation where the Schneiderian membrane folds over itself. That's kind of like what you want to do over here. You want to suture those so they just fold over the perforation so that they fold over themselves. And once I had that, then I went back in. I did the normal protocol of what we teach of vestibular incision and vestibular release. And of course, who did this happen to be on? This happened to be on a dentist's sister. And I'm actually going to be seeing her shortly. This was pretty recent in the winter. Going to be seeing her shortly to place these implants. So it actually does heal up. And, you know, it might be for the great membrane that there is also that'll last a long time.
Weren't you lucky you were using Ossex Plus here?
Indeed, I was.
So that's a huge advantage here. So he's going to end up having to leave some of it exposed somewhere, right?
Mm-hmm. Absolutely.
I love how calm you are here, because I know, I mean, this is like heartbreaking for me to watch, because I know that feeling. You're almost done with the surgery. You're in your head. You're going through the checklist of what you're doing. Again, refer back to that slide about the periosteal releasing incision where, you know, there's some advantages to doing it early. If we look at this, you know, you can kind of see, you know, he was going to perf if he was going to try to release more because of those stabilizing sutures he had in. But the handling here is really what's important, because you have to get some sort of closure here. You have to at least, you know, adapt the marginal tissue so that it has a chance of healing. But I bet this heals well. I've seen how closure.
Yeah, it did heal well. And this is one at it looks like a 5-0 suture. We haven't really spoken about it a ton, but I've since transitioned to only 6-0 sutures. And with the 5-0, this is really not so easy to do.
Yeah. Well, I mean, I thank you for sharing this, because to me, this is like, you know, something that it's very hard for us to take pictures of complications, let alone a video, and to share it. So
but the key is, like Matt said, to just stay calm and just get shit done. Just get it done.
Amazing. All right, and this leads sort of to a couple of other topics that I think are important to talk about. We already mentioned, you know, if you have infection, you're going to have more bleeding. You need to degranulate, and this will lead to a lot of other complications if you don't do this effectively, because you're not going to grow bone, right? You're going to have scar tissue. You're going to have soft tissue encapsulation. So very important to degranulate, although you have to be careful. There are certain areas where you don't want to do too much degranulating. And in those cases, if you have soft tissue in your socket and you can't degranulate because maybe you're too close to the sinus, this is one of those cases, the rare case where we won't graft, right? Take the tooth out and let it heal. Other times you can see where you have an infection, a large radiolucency, but the body sort of helped to confine that defect. So here, in this case, I took out the tooth. I had a pretty deep dehiscence, but it was very narrow. But I thought I was on easy street until I looked into the palatal root. And that palatal root, there was a tear of the Schneiderian membrane. It was small enough that I felt like if I could pack bone and use my Ossex Plus membrane, nothing fancy, just holding that membrane over that area, I went for more primary closure than I would normally do in a case where I have where I don't have a membrane tear. You know, I went for primary closure here just to be a little safe. You can see how beautiful it granulated in. It's inflamed, but it's closed and there's no infection. And then this is the healing at about 5 months. And I was able to do a little roll flap at the time of the implant surgery, and we had good bone. Didn't even have to raise the sinus because the body sort of did the job for me and expanded and mineralized around that. So this is something that used to be very tricky for me to figure out how to manage these. But really, you know, if you are using the biomaterials correctly, I think, and the perf is small, this will work.
Exactly. It's really about knowing your materials that you're working with and using them to your advantage.
Sure. And this is a case where I decided to do, like I told you, I didn't graft it. I felt like there was nothing to be obtained from grafting this area at the time of an extraction. I knew I was going to have to do a lift. I didn't want to have to go back in 3 months and be worried about what's bone and what's not bone. So I took it out and I just let it heal. Okay. I had a CT scan. I knew that the sinus was right there. So it was pretty incredible. The bone on the occlusal actually didn't heal. There was a defect there, but that membrane was completely intact. So it was pretty thin. I was able to lift it. I think I used a little PRF just for support. I never do that unless I have a tear, but the membrane was just so thin. And this is 5 months after that lateral wall. I was able to place my implant, had great bone. And so this is, stuff that we see every day. We're very, very, likely to graft most sockets that we see, but this is one of those cases where I try to avoid complications. And this is another case, just little simple things that I find during surgery that, you have to think of solutions for, like Israel did on his larger case. It's a case I've shown before where I'm using Ossix Plus to regenerate a buccal and a lingual defect. But take a look closely, look at my closure. What's going on the patient's left side? I couldn't fit my sutures between those teeth. I didn't think about it before the surgery, but there was absolutely no space. So luckily, one of the things I use a lot is periacryl for those palates, because I don't want to have bleeding palates. I'll use periacryl. And so I just used it in this case. I knew it wouldn't be a critical area. There was a lot of aesthetic issues and compromise to begin with, but it saved me because I didn't have a flap blowing in the wind.
Matt, are you like me on those cases where at first you try to floss the suture through and you watch it break 5 times before you go to
Yes, that is exactly what I do. I always do that. My assistants hate it because they have to get up and get another suture. But,
yeah.
This is something that you don't think about very often, but in certain areas of the mouth like this, you have to understand you cannot fit your suture needle through. Again, I got closure. This is the healing now. It opened a little bit too, and you can actually see how it's degranulated in despite it opening a bit. But we had excellent bone quality, able to place my implant, and we got to the finish line. So some of these speed bumps you're going to see on every case that you do, there's going to be some speed bump. But like Israel said, definitely just take it easy. Use your noggin and think about how, problem solve. That's what this is all about. This is what me and Israel were talking about if anybody was logged in before the lecture started, but this will bite you every time. And understanding that maxillary canine region, a lot of these teeth, that we're scheduled to take out, you're going to have a fenestration or large dehiscence like you see on these skull models. And this is definitely a time where you may want to start considering using PET. I mean, me and Israel are both dipping our toes into it. But the more of these cases we do, the more we say to ourselves, wow, like we're having to do so much larger bone grafting than we originally intended, because teeth that have a lot of history of endodontic treatment and some of these canines or isolated molars even will have ankylosis. And be prepared, because this can turn a very easy procedure into a very difficult procedure.
Cervical resorption, biggie.
Yeah, definitely. And we'll show later in the presentation how we approach these cases, when we have roots broken and things like that. But again, I'm not lying. This is something we have to deal with every day. Here's another canine, right? So this is a case where if you watch Israel's Instagram, you say, oh, just don't open it, right? But once it opens like that, once you see that you lose the whole buccal plate with your extraction, I feel like you have to open it to grow the bone outside the housing. And so in this case, I used almost like a putty. It's not a putty, but it's a fibrous bone graft. I didn't have my PRF available at that time. So we used it, and we were able to overbuild the area using sutures. So using sutures to stabilize and really overbuild the area. Again, that's an Ossix Plus membrane. And I know, Israel, you showed already some cases of using sutures, but I know you like to use tacks as well.
Yeah, so, there are cases where we'll use tacks for like a sausage technique, and we'll use sutures, periosseal stabilization sutures for an Ossix Plus type of case, like Matt was just showing right there, like we've showed many times. And then sometimes you have to think on your feet and be able to do both. So, there's so many people who come to the course and ask which one that we like better, which technique we like better. And it's really not one or the other. It's like, knowing how to do a chamfer without a shoulder, if my restorative recollection is correct. Is that right, Matt? Something like that? You can't only know a shoulder.
I've never been more impressed by you than I am right now that you just pulled that out.
Thank you very much. Yeah, I knew that would impress you. I impressed myself there.
But what's going on here? So it looks like you're trying to place a tack.
So I put the screws on the palate, and that went fine. And now I'm trying to put the screws on the facial for to create that sausage there. And you can see I already tried a couple of times, and for some reason I'm not able to get it in there. The screws are coming loose; they're tearing at the membrane. And by here I've already tried 4 or 5 times, and the next patient is getting antsy. They want to be seen, and your assistants are getting antsy. And by now, you kind of feel your front desk coming, your treatment coordinators at the front desk, they're coming into the room to take a peek at you, saying, what's going on there? And you're like, I'm just trying to get this in. I'm just trying to get this in, and hold the other next patient back. And you see, I'm trying and trying and trying. And there's some times where you just feel like, hey, you're all thumbs that day for some reason, or there's just not enough bone for you to work with. You have the adjacent roots. You obviously don't want to perforate into those roots or penetrate into those roots. And how many times have I adjusted that bone graft and now adding more bone? Because every time I'm doing this, I'm losing some. I'm losing the mound of bone that I'm trying to build. And so what I did is I extended this flap, you can see, because anytime you're doing periosteal stabilization sutures, you're really going to need to extend the flap to get good visibility. And hey, even though I had screws on the palate, for the facial aspect, I used a periosteal stabilization, the rib row sutures. And you got to be prepared for either way. And this is what it done. I don't do too many combination sausage rib roasts, but Matt might think it sounds tasty. A sausage rib roast, a rib roast sausage. And then you just continue on the same way like you do any type of stabilization suture. You just close it up, and it's the exact same protocol. But don't let the technique rule everything you do. You have to rule the technique, and you have to be able to adjust and think on your feet. And that's what this entire lecture is about, thinking on your feet and making adjustments.
I find it very difficult to put tacks and screws on the maxillary anterior, especially when there's a big concavity. And there's just no room, and you're having the patient open and then close and trying to figure out how to get that in there. It's very difficult to do. I know we always talk when we do our screws or tacks, you're usually trying to put it into the most difficult place first. And so you kind of think that's the palate, but I really think lately I've been switching it and doing the buccal first in this area only, because it's so darn difficult to get those screws in once you have the palate in, once you have that bone graft there.
Yep, completely. Although
all right, so one of the next things we'll talk about, moving on from what Israel was talking about, is I think why a lot of people are here, right? You do this beautiful bone graft. Here's the case I did. It was extractions at the same time. We did a sinus lift, and I put the 3 implants in. I almost never put 3 implants next to each other. If you ever see my cases, I love doing fixed bridges on implants. In this case, the patient had other ideas, and I said, let's do it. We can bone graft it. I have to bone graft the sinus anyway. And I did what I thought was one of the prettiest cases, I could possibly do. I was super satisfied, great closure. This is now 4 months later at uncovered. And the implants are stable. I have bone everywhere. But if you see some of my other cases through this presentation, most of the time I'm getting bone that looks like it's really getting some nice vascularity. In this case, I don't know what went wrong. And so I went back and looked at the pictures, and you can kind of see this picture before I closed. I have a lot of freeze-dried bone allograft in there, and I don't believe that I really scraped autogenous. I kind of got into a habit at this point where I wasn't scraping that much, especially when I was doing a lateral sinus lift on the same time. I just got a little bit lazy, and I really think, is this an acceptable result? Yeah, well, the implants have bone around them. They're healthy. But I'd like to be able to really rebuild the ridge. And this is, really showed me here, we're not growing as much as we want, and let's look at why. And one of the things I probably didn't do in this case either, because it was a maxillary arch, I said, oh, let's not do the intramural penetrations. And while it's very controversial, and there's studies that say that long-term, there's no difference, it just makes sense. And I find in my cases, if I don't do it, I'm not going to get that bone to incorporate as much as I'd like to.
And Matt, we just had a quick question exactly on this slide. This is the perfect slide. So we had a question by Vinley asking if can we get autogenous bone from the donor, from the graft, the site that we're grafting at that moment. And this is exactly it. Absolutely, yes.
Yeah, you try to get as much as you can. You have to avoid damage to adjacent teeth, but usually there's some area where even if it's a deep concavity, sometimes I'll still scrape that cortical bone, because then you're really making it bleed as well, which is great.
Yeah.
The challenging cases are the cases where you want to place an implant, a 4 millimeter implant in a 6 millimeter ridge, and do some sort of grafting on the buccal. And then you place your implant, and now you decide you want to have intraoral penetrations, but you're almost going to hit the implant, right? And so in a lot of those cases, you know, we'll use our Versa drills to expand the ridge a little bit, rather than just, you know, packing this inert bone graft material on the buccal plate without being able to have, you know, intraoral penetration. So bleeding to the site's key, and we'll always tell you, both of us always feel like we don't use enough autogenous. Even though we use it in almost every case, we don't use enough. The more you use, the better you're going to be. And this is what Israel does with it. He mixes, this looks like almost 50-50. I mean, it seems like you got I don't think I've ever had my safe scraper as filled up as you have it here.
Yeah, that's pretty good. And that's even just in between those teeth. That's not any dentulous area where it's really easy to get good scrapings. This is still in a dentate area. So it's not so easy. I'm kind of impressed by the amount of autogenous there too. That was a good one.
Yes. So, I mean, probably scraping for realistically 5 to 10 minutes here, but you know, it may feel like a long time, but it's going to be so worth it, because at least you're giving the body, you know, the potential to do the, you know, the most healing possible. Here's another thing that Israel does quite a bit. I'm starting to get into this game of using sticky bone, right? Because our biggest complaint, we never have the bone where we want it to be. Even that case that Israel showed you with the BioGuide membrane trying to be stretched. Well, how difficult is that to do if you don't have a bone graft that's staying in place?
Yeah, every now and then there's a patient who just doesn't produce good sticky bone or something, and I know it right off the bat. It's so easy to tell. It just, there are particles everywhere. It's not easy at all. There's nothing that helps your GBR quite like having sticky bone. It keeps it in the right spot. It improves handling, and whoever's not using it really, really should look into it.
And then I love this slide that you put together here, because this is also critical, because we're so focused on the buccal plate, right? We're so focused on the buccal plate, but you notice there's a deficiency on the lingual as well.
Yeah, so if you look at where the implant should go, you look at the adjacent tooth, and you can see if you put it just in there where the bone graft is, then it's going to be too far facial. You really want it right where the adjacent tooth is. And if you look on the top image, where that is, you'll basically have no palatal plate. So don't hesitate. Think three-dimensionally. Think exactly where it's going to be, where your future implant's going to be. And if you see that there's a palatal defect, graft that palate also.
Now, speaking of complications, and I wasn't planning on telling you this, but one of the complications I had today was a case where I was grafting tooth number 9, and I used an Osix Plus. And when I have a palatal defect, I'll use two membranes, one on the buccal, one on the lingual. Well, I went and looked into the lab bag when I was done to deliver the temporary, and it was a partial. And you can't get it to see because now we grafted the palate.
Essex.
I know. So this is real life. This is my patients texting me now, you know, when can I come in and get the Essex? So this is something that, you know, you have to prepare for. And if you're going to graft the palate, don't expect a partial denture to fit afterward.
Right.
All right. Implants. Israel likes to save implants, but sometimes he can't.
Yeah, I have a bin in my office. We call it the implant time machine, where we have all these old implants from way back when that every implant that I remove gets into a little pouch and gets put into this. And I'm hoping to open it up in 2050 or so. But anyways, here's one that got added to that bin. And, you know, this is a complication. If an implant, this wasn't my implant, but yes, believe it or not, some of my implants don't work also. And shocker, right, Matt? I know it never happens, but it can. This is a site where you just normally use it exactly like you do a GBR. Remove the implant. There are certain kits where you can remove an implant atraumatically and do exactly this to be able to just treat it like it's a GBR site. There's no problem with that. You don't have to let it heal beforehand. It's exactly like any GBR, any failing tooth. It does happen.
Yeah, and if you're worried, you could always extract and let it heal. Sometimes I'll do that, right? Patient had a failure. I'm going to extract the implant. I'll degranulate and let it heal, grow the soft tissue, just like we'll do for teeth that have too much infection, and then go back. And there's an advantage to that. Um, this slide here really, a lot of these things Israel mentioned earlier, they're not necessarily complications. They're things that are just going to happen if you're doing surgery. And so we want you guys to kind of understand that, because a lot of our students come to our class and they think that, if a patient gets swollen or if a patient has some bleeding after the surgery, that's a catastrophic failure. But in reality, you have to know biology, and you have to understand that the body will heal as long as you respect certain things. And obviously the most important thing on this slide is probably nerve injury. So we'll cover that first. Super important. Obviously, if you guys have ever had a nerve injury case in your practice, it's a life changer, right? Because these patients you become married to. So first and foremost, obviously you don't want to have any paresthesia of the tongue. Stay away from the area distal, to the retromolar area. Always use that buccal hockey stick incision. I love that incision if I'm taking out lower molars, and I want to do a little buccal dehiscence graft. I'll just break that incision. It allows me to get great closure and release tension without having to make a big flap. But you always need to stay away. And then it's obvious, no vertical incisions in the area of the premolar. I had a couple of these cases referred to me where patients were having a simple procedure done by their general dentist or another doctor, and they've gotten paresthesia from incisions in this area. So, that's an obvious no-no. Again, going back to the CT scan and just knowing where your anatomy is. But I think the more elusive concept is, when you start raising flaps in this area, right? And so we do this a lot in our course, and we actually can practice on pig jaws, and you can kind of, get a feel for, number one, how you want your flap to be raised. You need it to be raised full thickness. If you're not raising the flap full thickness, you're gonna have a lot of soft tissue tags. And sometimes you need two hands to do that. One to grip the flap margin, and then another instrument to elevate the flap. And then as you get close to the nerve, a lot of us periodontists, we were taught to use soft, some wet gauze ahead of your elevator, like you just saw, just to isolate that nerve, right? Now, once you have that nerve isolated, you're supposed to have to do this periosteal releasing incision to get primary closure without tension. Well, how do we do that if the nerve is there? Well, the trick is, number one, to know your anatomy very, very well, and to use the information that we have from clinicians that came before us that have done a great job elucidating this. And so Israel really illustrates this well here.
Yeah, so you can see over here, I'm making my vestibular incision in order to get my release with this GBR case. And you can see I'm starting towards the back pretty apically. And then as I get towards that mental foramen, I move away from it. So I move towards the gingival margin. And you can see the angulation of my blade actually changes. And now you can see how you end up having this almost like a mountain, a ski slope. And you can take that measurement, and there I am exactly 10 millimeters away from the foramen, which is the minimum distance of how you should be. And so really just, people often ask, and we focus on it in our course, of how do you make your incisions? How do you release around the mental foramen? And you have to be able to. It's just a matter of knowing exactly where to do it. Stay away from the nerve.
And so the key things to remember, what we teach in our courses, is you only need a 1 millimeter deep incision. And the way to do that is by, number one, having a fresh blade, right? And then try to do a single incision, a single continuous incision. Obviously, sometimes you have to break it up, but as single as you can. And then we'll do some stretching within that flap. And if you're interested in the article that both of us probably referred to, it's this Rhonda article from I.J. Perio. It's a great illustration. And I believe they also have literature on the lingual flap release, which we use quite a bit as well.
Yeah.
So that's sort of the tricks to everything that we do. The other way we can get nerve injury during a surgery is obviously with implants. And nowadays Israel's doing a lot of guided cases. I'm dipping my toes into it. But one thing that I really refuse to work without is these, depth stops. Every implant company makes their own version of them. This is BioHorizons, and it comes in the 2/8 drill. And I'll just drill to depth with this drill because it's like takes away one factor, one component, and it allows us to respect that 2 millimeters away from the nerve that we know we need to have minimum.
Those are really
right?
cool.
Yeah, super easy. I know a lot of the companies, they'll make the disposable ones that go on the bits. Those work as well. I like to be brainless. So this drill comes in, every size that they basically, the implant sizes. but it's just that second drill, which is for me is all I really need. It's to get to depth. Once you get to depth, then I can, move forward with my other drills. So this not only makes your life easier, but it really protects your patients.
Speaking of nerves.
Speaking of nerves, right.
Yeah.
This is what you want to see in your office.
So this is a case that I had where he had just a wee bit infection around that distal root of that lower left molar. And, obviously knew there was going to be a lot of granulomatous tissue, and looking at the CT scan, you scroll through it and you can really see how there are sections over here where there's no separation between the infraalveolar nerve and the soft tissue, granulomatous tissue around the tooth. So I knew this would be a bit of a challenge, but again, there are certain ways of treating this. And as long as you know techniques, you know your materials, that's what you do. So when you have a case like that, what's best is using a buser or a spoon, but use it face down. And you can, I don't know if you can see my hands over here, but use it the spoon side down. So you kind of push and you lift with a tissue forceps, and it really separates pretty easily. Even if there is actual touching between the nerve space and the granulation tissue, it really does separate easily. You just obviously have to go really slowly and be very careful around that.
And I don't know if you're using my trick, because I know you've gotten away from Paradex completely, but I'll still use the Paradex to irrigate the sockets, because I find it really makes it much easier to degranulate once you hit it with the Paradex.
Yeah, I always forget that, but no, good reminder.
All right, so Israel did a pretty amazing job trying to maintain the space using these tenting screws.
Yeah, so this is a case where there was a lot of, obviously couldn't go apical to place those tenting screws. So I thought of, how am I going to maintain this height? I wanted to use resorbable membranes. So I didn't want to use a titanium reinforced cytoplast in this case. And so I used those tenting screws placed mesial and distal into native bone. So you look at this x-ray and you say, oh my God, what exactly did I do here? But stay calm. Always stay calm. And I actually had the patient get up and took a CT scan so that I can really see exactly where this was. And I saw that it was penetrating into the lingual space, which frankly, I'll take. If I have a choice between lingual space or the infraalveolar nerve, I'll take that lingual space, especially in that area, since I knew that the soft tissue was released from the area. It was elevated, and I wasn't going into any artery there or anything like that. So once I saw that I was perforating into the lingual space, then that was better. Then I can reposition it. And believe it or not, a few days later, the restorative office called us and asked for an x-ray of the surgery. And for some reason, a front desk person at the time, I don't remember who it was, but I doubt it's anybody who's still with me, sent that x-ray to the restorative doctor. That was the one x-ray they sent. And I caught wind of that. And yeah, that was not a good day. Had to call and explain some stuff here. So this turned into a normal GBR after that. There's my bone. There's my Os6 Plus with the periosseal suturing, PRF on top, and then primary closure. And this is what it looks like once it all heals. And this is after 9 months of healing. You could see the mesial screw. You cannot see the distal screw. You can't even see it. And after I tried to uncover it, I said, why am I even uncovering it? It's hidden bone. There's no reason to just let it be. And that's what I ended up doing, letting that screw be. It's hidden under bone, and we'll never hear from it again.
Beautiful. All right. Well, to finish off this section, this is very important that, everybody understand. Number one, if you ever have nerve injury, there's certain steps that you need to take. I mean, you need to be mapping these areas, but really the appropriate advice is you need to have a referral ready. There are people that do repair nerves, and the earlier they get these cases, the better chance that they can repair them. And so I know a lot of us don't want to do it. You feel in the back of your head that, give it some time. And a lot of them will get better on their own if it's not a sectioning of the nerve. But you really need, if you don't know how to do neurosensory testing really, accurately, you really need to be referring these patients out. I believe the general rule is about 6 weeks, but
Yeah.
I think for me, I would give you the suggestion of 2 weeks, because the earlier the better. Let them start mapping this the right way, and protect yourself, because this can happen. It's happened to all of us. I remember when I was in residency, they used to always say, it's a good thing if you hit a nerve in training, because then you won't hit one in real life, just in that respect. But it's a really terrible thing to have to go through for patients. So you have to do everything possible to avoid that.
What's your first thing to do in terms of medications?
I find it silly because we're always taught to give the Medrol first, give some steroids to get the inflammation down. But I think really what's important is to figure out what's causing the nerve injury, right? I've seen a lot of cases where patients just ignored large lucencies, in the premolar or molar region on the mandible, and they'll come to me with nerve injury to begin with, right? So in those cases, what's caused it. I'm going to take out those teeth. I'm not going to graft the sockets. I'm just going to let it heal. I've seen some of them spontaneously get better, but other ones are, they're permanently damaged from having the infection literally eat out the nerve. The majority of the time, in these cases, if you just rubbed up against the nerve, there's a good chance that it may start to come back. But if the nerve is completely severed, it doesn't matter what medication you give them. And I know there's also laser therapy that's been proposed. I really feel like you need to get these people. There are specialists that do this. It's incredible that they can do it, but they do it, and they move the nerve canal when they need to, and they can try to repair it. And that's what you need to do. You need to get these patients to the right place. In terms of postoperative pain, this is something that obviously we all have to deal with. Pain, again, is not necessarily a complication. I mean, we're doing surgery. I always tell patients when they complain about, surgery, we're literally regrowing a body part. So, they're going to feel the pulsating of the blood vessels, the angiogenesis. That's normal, especially if they get their blood pressure up. But I think, all of us can agree, one of the tricks to having patients not have a complicated post-op and a lot of pain is to really not to let that pain set in to begin with. Which is why, using longer lasting anesthetics are going to be very effective. I truly don't find that patients need opioids after bone grafting procedures, maybe just for the placebo effect. They like to have it. NSAIDs really do the job in most of my cases. But things, every patient's different. I read that study where, redheads actually have a higher propensity to have pain after surgery. So you have to know your patients well and make sure that they're covered and they understand that they will get better. They just need some time. And this is a case where I thought, this patient was surely going to have pain. I did so much here. You can see my incision here, my periosteal release. You can even see where I harvested some autogenous from the ramus there. And she had no pain. She thought this was a breeze. She'd come back to do the other side. Everything was great. A little bit of a soft tissue deficiency at the time of uncovery because I had to get primary closure at the initial surgery. And there's the bone graft. You can see with the Os6 Plus turned over completely. I did a little soft tissue grafting. And then she came in for the post-op and she was absolutely miserable. So I thought maybe it was coming from the palate where I took the CT graft. No, it was the lower. And I looked in her mouth and I was relieved to see that the implant sites looked beautiful and everything was healing great. But you can notice on the tongue, the healing abutment was rubbing against the tongue. So, you can never be too cautious. You always have to think of the small details because something like this really could drive a patient insane. It's very uncomfortable. They can't eat. And, what I did was, even though I don't like doing this, I ended up shortening the healing abutment and putting a shorter and wider healing abutment in there. I'm not sure why I didn't do that at the time of surgery, but, patients get used to not having teeth there and their tongue wants to go to that area. So keep in mind, there are other ways that patients are going to experience discomfort or pain. Sometimes it's from wearing the denture or the partial that they have. So figure out what's causing the pain.
It's really amazing to have that large bone graft and look so beautiful. And it's just a healing abutment that ends up causing a little canker sore and ulcer that hurts more than anything else.
And I was just so worried that, to put a short healing abutment and then have to worry that the gum was going to grow over it. And so I went with this narrow, tall abutment because that's all I had. And it drove her nuts. This is the other issue, right? Swelling. We're going to have post-op swelling. There are ways to minimize swelling. And a lot of it has to do with that 1 millimeter deep incision we're doing. But even more than that, and I've learned a lot more about this from Israel over the last couple of years, is not even doing surgery to begin with, right? Doing everything, within a very small incision or no incision. And that's always going to be our goal, because we need to avoid this. And if any of you are out there are general dentists, this is like a practice killer, right? The patient showing up 2 days after surgery like this in your waiting room, right? And everybody in their waiting room is thinking, oh my God, what did they have done? So they're always,
Everybody in our waiting room knows that people are there to have surgery. People
yeah,
expect it.
right.
Everybody in a general dentist waiting room, it's like, wow, that's some filling she got.
Yeah. And I think the trickiest thing is most patients don't get the swelling till the third or fourth day. And so a lot of times they feel so good on that second or third day, and then they wake up to this on the fourth day. And this isn't as bad, the worst I've seen. This is just one I got a picture of, obviously. I mean, patients can get very swollen for these large bone grafts. You have to understand that, ice the first couple of days is shown to not really scientifically make them heal any better, but I find that they do feel better with it. So we do that a lot. And Israel, why don't you tell them a little bit about Arnica? Because I've started using it and it's really worked.
Yeah, so Arnica montana is a homeopathic anti-inflammatory that, if you go to Whole Foods, you'll find that there's a couple of huge, massive shelves full of Arnica, and they're all different dosages and different types and everything. And there was one study in the plastic surgery literature that researched a specific type of Arnica and specific dosage, and found that at certain time periods after surgery, the patients did have less swelling and report less discomfort and had less bruising. And so this company called Alpine Pharmaceutical, they took it and they formulated it, and they sell it to plastic surgery, to ENTs, to oral surgery, periodontists, whoever you want. And it is not inexpensive, but it's really, really good stuff. And we give it to all patients post-operatively, and patients love it. They really report amazing
Yeah,
stuff.
and I've started to do the same, just from what Israel taught me. And I was very skeptical, but I figured, it's worth a shot, and it really does help. Neither of us really prescribe steroids regularly. A lot of people like to do that. Both of us are pretty opposed to it. There's side effects to steroids. And so if I could avoid the steroids, I will. This patient was actually allergic to penicillin, or no, excuse me, she was on methotrexate, so she couldn't take penicillin, and she was allergic to aspirin. So no ibuprofen. She was just taking Tylenol. And unfortunately, once you get this swelling, a lot of times that's what brings the pain with it, right? So it's a good idea to do everything possible to try to minimize this type of post-operative sequela. The next
Good
thing is
questions
bruising.
coming. We will review them afterwards. We see them all.
Okay, great. This is another amazing patient of mine where this was a full arch reconstruction. And she's on blood thinners, and we got medical clearance to get her off the blood thinners. But unfortunately, we kind of expected this. She was going to have quite a bit of bruising. And you could see her. She was jolly the whole time. She had no
Good
pain.
thing she didn't. This is nothing, right?
Yeah, and she took the pictures herself, and she started on the second day, and she has the second day, and then the third day. And what we always tell patients, it's usually the worst on the fourth day. If you look at these pictures, this is exactly the peak. And then after the fourth day, it starts to get better very, very quickly, from day 7 to day 8, and then all the way through to day 10. So this is not a case that I'm proud of. This is one of those cases, like, again, you don't want these patients in a waiting room. You want them to call you, on your secret line and sneak them in the back, and just let them know that everything's going to be okay. This is not a sign that anything's going wrong. And in my experience, actually, a lot of these cases do really well because of all the bleeding. The blood supply is so important that I find that they do very, very well. Here's another sinus lift case where I did a simultaneous bridge jog, and you can see the healing of the lift despite the patient getting so bruised. She stayed calm and she did very well, and you can see the bone turnover. So it's not a sign of anything failing. We want to try to minimize this as much as we can, but it's not always possible. Every patient has a different propensity for swelling and bruising.
I warn all patients about sinus lifts. If I have to do a lateral window, that, on the good side, it really doesn't hurt a whole lot. But I say, man, it really causes a ton of swelling and bruising. There's no question about it.
Yeah.
And the more they know about that beforehand, the better off they are. So always, always, always warn them on any case. We're showing GBR, sinus, anything. Warn them about the amount of swelling. If they don't swell or bruise like crazy, then you're a hero. But if you didn't warn them, obviously, then it's an excuse afterwards.
Right. All right. And now one of the probably the most frustrating things about, surgeries, you could do the best surgery you've ever done in your life and you can still get infection. It's just what's, it's going to be either it's in the cards or it's not. And that's very frustrating because a lot of the time, we'll do these cases where we're doing a tremendous amount of grafting and you have certain doubts in your head and those cases heal great. And other times you have a case where you do a GBR and everything goes great. These are two cases where I use PTFE. And I know I always say this, but like the quality of these pictures like tells you what I was feeling. I can't even take a straight picture when I'm in these situations because the patients are in pain and they're suppurating and they're pussing. And I always mention this as well. These are both late failures. So this is not something that, a week after the surgery, I see the patient for a post-op and they're pussing. Look at the incision lines. They're gone. These are late failures. And this is a real problem with using non-resorbable materials. So you have to understand that. And then I think also very important for us to talk about a little bit is, antibiotics, because it's a prerequisite for me when I'm doing implants or bone grafts to use preoperative antibiotics. I do everything I can to do that. And, I always quote this Wagenberg article because this was a side note of this study that they've noticed that patients that were allergic to penicillin have a 3 times greater risk of post-op infection. And I challenge you to look back at your cases and look at your implant failures. And I guarantee you,
that's 3 times, not 3% increased risk.
Yes, I'm sorry about that. That's a typo.
You mentioned it correctly. You said it correctly. Yeah.
Yes, 3 times greater risk. So I challenge you to look back at your implant failures, and most of the time it's patients allergic to penicillin. And it's a challenge on what we put them on. I usually will go with clindamycin, even though I know it doesn't work great. Israel, what is your go-to if patients are allergic to penicillin?
Omnicef.
It's a I always forget.
It's a 4th generation ceftonir. Same thing. It's a 4th generation cephalosporin and has no cross reactivity to amoxicillin. So yeah, that was actually told to me by a neighbor of mine who's an orthopedic surgeon that's what they do. He told me that a few years ago and I ran with it since then. And yeah, it's great.
And talk us through this case. So this looks like an interesting one. Looks like number 9 has fistula.
Yeah, so there's a fistula between 9 and 10, and really that's overtaken both teeth, the infection. And you can see number 1, how the soft tissue on number 9, first of all, you can see how the tooth is pushed coronally, caught by the apical infection. And you can also see it has some recession there. The gingival margin is more apical than it is on the right central incisor. Super nice guy, just really a wonderful, wonderful patient. And, I do a GBR with a titanium reinforced cytoplast.
But let me ask you something. This is interesting because I think did you just extract the teeth in this case and let it heal before you went back to do the GBR?
So I did not. So I did it. I may have actually, looking at this, I did. So I took out the teeth and I did let it heal before going back. That's exactly.
And I think that's an important point because we love to GBR at the time of an extraction, but if you already lost what you're going to lose, it's already gone. Then might as well get rid of the infection and now at least have some soft tissue to work with.
Yeah, looking at this, because when you have the recession, there's no way of being able to pull it down that much. If I know I'm going to be using, something we talk about in the course is I never use a non-resorbable membrane at the time of extraction. I just don't. I think the increased risk is not worth it. So if I'm going to be using a titanium reinforced membrane, a cytoplast membrane, then I'll take out the teeth, let it heal, have a healed ridge to work with. You have more soft tissue to work with. So in this case, everything looked good early on. And then like Matt's case, he has a late exposure. And you can see the first thing I did is try to trim that membrane, trim the exposed area to get that soft tissue, to heal. And you can see that middle picture at the bottom. It did start to heal, but that exposure gets bigger. And that's what happens. And then you end up chasing your tail because it's getting bigger and you keep trying to trim it. So finally I got to the point where I opened it up. I said, I can't keep letting this get bigger. And I removed what was left of the titanium reinforced cytoplasts. And you can see there's still some bone regeneration. There's no question about it. but it's just not as much as I would have liked if I had not gotten that exposure. And it's just a common risk, and the literature shows it's a 30% risk of soft tissue dehiscence around these non-resorbable membranes, which is why Matt and I really love resorbable membranes a lot.
And we just got a great question. If you're going to do it this way, which I think we recommend, even though this didn't work out perfectly, just because of how much regeneration you needed to do, the question is, if you're not going to if you're not going to graft at the time of extraction, how long to wait? And for me, the minimum is 6 weeks, because that's how long it really takes the soft tissue to heal. I think it's a little wiser to wait even longer, because when you open it, you'll know what's bone and you'll know what's, scar tissue.
Yeah, I typically tell the patients 2 to 3 months.
Yeah.
And it ends up being 2 months because no one wants to wait 3.
Yep.
So thankfully saved by the low lip line. And this is what he looked like when he was restored. Obviously not what I was hoping for from the beginning, but you run with the punches, and you manage what you can do. And just about knowing what to expect, what can you expect out of these things, and knowing that he has that low lip line, I was very happy with that. And he's thrilled to death with this, to be honest.
Yeah, and if he didn't, then you would have had to go back and maybe do a soft tissue graft and then maybe another vertical GBR, right. But it's case dependent.
Exactly.
Titanium mesh is no different. This is a case we'll move through very quickly. Just exposure again. You can see the incision line's gone, case exposed. And the literature says you can baby a little bit, maybe trim some sharp edges if there are any. In this case, there really wasn't much for me to do other than baby it. And again, it just got worse and worse, just opened. And so these are things you want to be aware of. Now, let's contrast that with this case where I did a immediate placement of the front site. Lower back posterior site was just a mild deficiency there. The buccal plate was very thin. And then I went and used my Ossex Plus membrane and I got closure. And at the time of the surgery, I thought everything went great. Look at the photos closer. And I didn't see this in the mouth, all right? And you can get closure here. You can see I was kind of penetrating through the lingual. And this is more so how it looks in the mouth. It's very hard to pick up these little details unless you're taking these photos. But I went and looked back when this is how the patient showed up at 1 week. So 7 to 10 days, probably closer to 10. So again, these patients are not the most comfortable patients in the world. You can see the flap margin basically was either too tight or it just lost blood supply because of that perforation that I had in that lingual aspect of the flap. But no infection. That's key. The patient was on an antibiotic and was not infected. So you do have to baby these a little bit. These patients will sometimes call you and say, I think I may be infected, because they see the white epithelium now trying to migrate over the wound. But if you're patient, and you wait, the soft tissue does heal. And, in these cases with a collagen membrane, I could go back and regraft a little bit if I need to. In this case, luckily I didn't need to.
There's still, for some reason, a very common misconception that you cannot leave collagen membranes exposed in the mouth. And that's absolutely not true. You can leave collagen membranes exposed in the mouth. You just at that point need something that's long lasting. So if you're I purposely leave collagen membranes every day exposed purposely. You just need something long lasting, and really nothing lasts longer than Ossex Plus. I think that we can all definitely agree to
But
that.
if we're doing a ridge augmentation, that's when maybe we'll want to get primary closure because of the amount that we're grafting, right? We don't want to lose bone.
Yeah. I'm not saying that I do a ridge augmentation exactly. Good to point that out. It's not ridge augmentation that you're leaving membranes exposed. It's ridge preservation. It's extraction sockets where you leave the membrane exposed.
And then sometimes you do a ridge aug, right? A crazy ridge aug at the time of an extraction and implant placement, because everybody wants things done right away. And then your referring dentist sends you this photo a week later that the patient's in the office and they're very uncomfortable and they want to know if they should resuture this for you. And so, this is an area of the mouth that is probably the most prone to opening. The blood supply of the mandible is very, very minimal compared to other areas. And there's just a lot of tension on the flap. And even you can just imagine this patient standing in front of the mirror, pulling her lip down, looking at it, is not making it any better. With that said, I use materials that I'm very comfortable with. And this is a couple weeks later. It does heal. And I was very lucky. Really, the only places that it opened were the areas where I didn't do the large grafting. And so, we didn't flap this back open. We used a punch to expose the implants. But she's doing very, very well. And this is now a couple of years out. So, the advantage of it inadvertently opening is sometimes you'll get this really thick band of keratinized tissue, which you can use. If it's an aesthetic area, that's a different story. But luckily here we were okay. And that really is what drives a lot of the bone grafts I do. So even in cases here where I have these severe dehiscences at the time of an extraction, like we said, for extractions, I'm not so worried about getting primary closure. This is a very difficult site to get primary closure unless you're putting verticals, right next to the defect, which I don't like to do. So I'll place one vertical, I'll get primary closure, and then I'm okay with the amount of hotness I have at 1 week here, right? It looks very hot, but again, it's not infected. But it's knowing the biomaterials you're using and allowing this to heal. And this is one where, we grew a tumor of bone here, and probably too much. This is when I was kind of overcorrecting a little bit too much. But it really is amazing to see the quality of the bone that I had underneath, despite the fact that we left it a little bit open. So I think we've been complicating things quite a bit. And once you realize that you can leave these open, I know Israel does this sort of thing. I think he's going to make fun of me for using chromic gut, but that's all I had at the time. And so I used the chromic gut and it worked out just fine. This was the uncovery at about 5 months, and actually had beautiful crowns made by her prosthodontist, Dr. Amber Pagani. So this type of stuff that used to be very challenging, can be done relatively atraumatically. This patient doesn't get the swelling because we're not doing the periosteal releasing, right? These patients usually do quite well. Right. They just have to know not to mess with the area and to allow the area to heal, and let the skin, grow over the area. And this is exactly what Israel was talking about. I love this case just to show you. This is 7 to 10 days after the membrane was left exposed. It's almost entirely intact. There's no infection. I removed the sutures. And then just 2 weeks later, we have granulation in over the defect. And then, of course, 4 or 5 months later, we can go back and place our implant. There's no remnants of particulate material. It's solid bone. So this drives a lot of what we do. Israel, we only have a couple minutes left, so we'll move through these last couple of cases quickly. I think the last 2 cases we have are probably the most worthwhile for us to show. But you can talk.
So, Matt was talking about early on about what happens when you do a large ridge augmentation, and do you always get exactly the bone that you want? And the answer is no. So, look at this case. They did a really large ridge aug using an awesome membrane, and you expect to have an amazing amount of bone to come back to, and you don't always get that. You get it, thankfully, the vast majority of times, but sometimes you don't. And so in a case like this, I didn't. And so what do? You adapt and you regraft. So you place the implants, and yes, I regraft. I know it's not the material's fault. It's just for whatever reason, the body tends to go to homeostasis. And the more and more that I look at cases over the years, the cases where you end up not getting as much bone as what you want, they tend to be the ones where you look around at the adjacent teeth, at the adjacent ridge, and you see that this person just has a very narrow alveolar ridge. And so if you have a narrow ridge and then a huge balloon of bone outside of it, it tends to shrink up. So in this case, go back and just continue on the exact same way. Add my implants, add the bone graft, do a periosteal suturing, stabilization suture with Ossex Plus, and just regraft. And that's okay. It's a complication, but it's a complication that is very manageable. You just have to know it and prepare patients for it also.
Yeah, and this is what we see all the time. This is a case that was referred to me by her dentist who extracted the tooth. I went back 4 months later. They hadn't done any grafting, but I don't think they did a great job of degranulating the socket either. And so when I got in there to place my implant, I really, was stuck in between a rock and a hard place, because I didn't want to not place the implant, but I was worried about what was actually bone and what was maybe residual infection or scar tissue. And so, go back to basics, and we clean out the area, follow the protocol, and try to maintain that buccal-occlusal line angle, because I think that's really the most important thing to understand. If you're going to be doing a bone graft, the bone has to end up where you need it. And that's why we like the stabilization sutures, because it allows us to do that. But we'll get, full bone. So just because a patient didn't heal, right the first time, go back to basics, and you can make this happen. These are not difficult surgeries. This is, again, the canine that always will haunt you.
Yeah. Canine's a very thin buccal plate, in this case, non-existent buccal plate. And here I used a Volumax to be able to use as the membrane. And I used that as the membrane with the periosteal stabilization suture. But you can see this patient is just a thin gingival biotype, has adjacent crowns, and perhaps didn't quite recognize how thin and how much exposure there could be, because you look at the post-operative and all of a sudden the patient has a recession on the adjacent crowns, and you think that patient's all that thrilled with it. Probably not. Got decent bone, not an excessive amount of bone in this case. Also, this is a patient just with a really thin ridge all around. And I used my Versa to do a little bit of ridge expansion, still graft around it, place the implant, and try to use materials to combat the amount of recession that you have. Probably put an allograft in there and then bring that tissue down. Is that going to fix it? Not all that much. You look at this case where the canine, the implant probably looks like the best tooth around there. Thankfully, this patient, honestly, super sweet patient. She was bringing me gifts after this, but I'm looking at it and seeing that she has now recession after the surgery. So, you know, it's in consent forms, but in addition to being in consent forms about recession on adjacent teeth, it's something that we should probably mention, especially when there are crowns.
And I think we all under treatment plan these quite a bit, right? Because a lot of times too, these cases will come in with a little inflammation of the marginal gingiva, and you get in there, and part of what we do as surgeons, we're cleaning up the area, and then the tissue is gonna shrink. And so a lot of it has to do with, you know, the patient expectations and letting them know maybe from the beginning that this is a good case to really, you know, deal with the soft tissue by maybe putting new crowns on the adjacent teeth. You know, I'm just going to kind of use this slide as sort of the closer and as sort of the introduction to maybe a second section when we'll talk a little bit more about maybe soft tissue volume complications. Both of us are using a lot of old techniques like using partials and healing abutments. But we're also using Volumax now at the time of an extraction. And I just want to pull up your last case here. This is another good point where Israel used a beautiful semi-lunar incision or almost a vista incision to avoid touching the marginal gingiva, because that's so important.
Yeah, the gingival tissue is a little bit apical in that extent, and Matt did the same thing on this one. Try to avoid complications. You're going to have more recession when you touch the marginal tissue. If you don't have to, then you don't have to.
And then this will be our last case that we'll show you guys tonight. So Israel did a beautiful bone graft. But of course, even though he established, you know, a good amount of bone to support his implant, he always feels like he wants to have that 2 millimeters of bone buckled to the implant, and he needs to worry more about soft tissue than anything else. So what did you do in this case?
So in this case, you know, I did my GBR, and here's another one where I didn't get quite amount of bone graft that I wanted to. So I still using a surgical guide, placed the implant, and you can see that buccal bone was a little bit thin. So that's a customized healing abutment that I had placed, made by my lab pre-surgically. And in this case, I used Volumax, which, as everybody here knows, probably is a similar material to Ossix Plus that can be used when you have a very thin ridge, and it ossifies over time. That's the beauty of it. And I placed it over that thin ridge, sutured up around the customized healing abutment, and let the soft tissue heal giving it a really good, nice emergence. And then this is what it looked like after a little bit of healing and after restoration. And even though there's thin buccal ridge, you would have no idea now. It just looks fantastic. Great prosthodontist worked on that one too.
Periodontist wasn't bad either. Well, I think we've reached our limit. I'm going to take a look and see if there's any, you know, relevant questions for us to answer. We do appreciate you guys all, you know, coming and joining us and you know, hanging in there for us to kind of show you some of the mistakes we make on a daily basis, and we're always trying to improve, and we're glad that you guys are here and trying to do the same thing. If you're interested in any of our courses, you know, you can scan the QR code down there, and hopefully maybe we'll be able to schedule maybe a part 2 complications webinar coming up soon. I think there's plenty of material between the two of us. I've got a great question here that asks, and I'll ask it in Israel. You can give the answer. I'll put you on the spot. But the
Perfect.
question is, why is it okay to leave the membrane exposed in the case of ridge preservation, but not ridge augmentation?
The answer is because. No, the answer is that in a ridge preservation, you have four walls of bone, and all you're really doing is containing the blood clot so that you can start to form bone within that socket. You basically have a hole that you're growing bone within. As long as blood fills that up, you're going to grow bone. The purpose of the bone graft is just to help preserve the dimension, the ridge shape. In a ridge augmentation, you don't have that wall. So you're much more likely to have collapse. And if you have that membrane get exposed, it's going to resorb more quickly. And even a membrane like Os6 Plus is going to resorb more quickly. It may not be over a week or so, but it's going to resorb more quickly, and you'll end up losing that volume. So on a ridge augmentation, you always want that soft tissue closure to make sure you have that closed environment. In a preservation, you need it much less so.
I love that answer. I'm not even gonna add anything to it. I agree completely. Someone asked, when left exposed, how long does it take Os6 to resorb? Well, you can take a look back at the case that I showed of just that simple socket. So, epithelial cells are going to migrate about 1 millimeter a day. So it's going to take just as long, really, for soft tissue to grow over it as it would if it wasn't there, right? But it really will resorb within a week or two. But I don't believe that it's actually fully resorbing. I just think it's so biocompatible that epithelial cells are migrating over it. And we've done a whole nother webinar just on the idea of this Os6 Plus, how when we go back, and you could see it in Israel's case with his tenting screws, you can see the mineralized Os6 Plus on that ridge, over that ridge at the time of implant placement. So that material will stick around for quite a while. I've seen 9 months post GBR where I'll flap it open and that material, the remnants of that material will still be in place.
Yeah.
This is another question for you, Israel, because of that. I knew that beautiful custom abutment case, but they want to know what special instructions do you give to lab to make that custom abutment. I'll preface the answer just to speed things up for Israel a little bit. He's doing a lot of the hard work by planning the case. So they're planning the case, and usually Israel is pretty good. He'll make a temporary abutment a lot of times, right? A crown, and he'll make a custom abutment, so he has a backup plan. But it's planned from the prosthetically driven.
Yeah, this is really something that has taken a lot of time with my lab to be able to design, and they know exactly how I like it. But I do design each case with them on a via WebEx or something like that, Team Viewer, and we'll sit there and we'll design the exact placement of the implant. Where is it going to go? And they know how I like the customized healing abutment to be, and I'll have it prefabricated. And then always use a surgical guide for those cases, because you want that customized healing abutment to be in the exact spot it has to be.
And there's some other options. I use something called the iShell, which is basically a shell that you can prefabricate, or you can fabricate after implant placement in the mouth. But these are all things that take time, and after surgery, you want to get on to the next surgery. And if you can have it done preoperatively, it obviously, will minimize complications. Someone else wants to know the name of the antibiotic that Israel prescribes is Omnicef.
Yeah, Cefdinir is, I believe, the Omnicef is the brand name. Cefdinir is the generic.
For stabilization sutures, they want to know what sutures we use. I was using chromic gut for years, 4.0 or 5.0 chromic gut. Both of us are using Glycolon just because it's a little bit stronger. It's going to last for about 6 weeks, and we don't have to worry about it getting loose. It's also a little bit easier handling. So, the last thing you want to do is be placing that biting incision into the bite into the periosteum. And you saw Israel working on some of his bone grafts during this lecture. And once you get that complete, the last thing you want is for a suture to come loose. So Glycolon is resorbable. It's a monofilament. It doesn't wick bacteria. And so it's a great option for those periosteal sutures. I don't know if you need anything that lasts longer than chromic gut, to be honest, but the Glycolon's been very easy to work with. So we've both been using that quite a bit.
The arnica, it's not prescription. Somebody mentioned here, they give it to every patient via Amazon or something like that. And exactly, you can find it on Amazon. It's just more expensive on Amazon than if you buy it through the company. And through the company, the more you buy, the cheaper your price. And we buy a ton. So I think we've got it down for the big box down to, I think about $15 per box, something like that.
All right. I think the last question that we can close with basically is asking if you have a late stage, maybe 2-3 months after implant surgery or bone graft surgery, you have a non-resorbable membrane that gets exposed and there's suppuration. Are you going to open it and clean it and then maybe place a collagen membrane? And the answer is, you can do that, but I think Israel and I both, when you have a failure with suppuration, I don't know that I feel comfortable throwing more biologic materials at the site without knowing that it's really clean. I've had cases where I've gotten suppuration from maybe a PTFE suture that was left a little bit too long. And in those cases, I'll have to maybe open it a tiny bit to snip out that suture, and I'll see a little pus. And you do the best you can to try to differentiate what's infection and what's not. A lot of irrigation, but a lot of times if you can just isolate where that infection is coming from and you can degranulate in that area, you don't necessarily have to start over and clean out the whole area. Now, if this is in the sinus, then yeah, usually you do. I've had that happen where a sinus gets infected from a lateral wall and you have to go back and really, start from scratch and clean out the whole thing. But in those cases, you really need to cut your losses. If you have a failure, take a step back and try to figure out, was it the patient's medical history? Some patients are smokers and they don't tell you you're smokers. So there's a lot of things that could cause the failure. You need to identify that failure. Don't just start throwing more materials at it and expect to have a different result.
That's right.
All right. Well, thank you all for joining us. It was a pleasure. I was just happy I got to spend an hour and a half in person with one of my favorite people, Dr. Puterman.
Me.
And yeah, you.
Thank you. Thank you. The feeling is very mutual.
All right. Well, we'll see you all next time. Thank you.
Thank you very much, everybody. Thank you for the great talk, Israel and Matt. It was amazing. We have very good feedback coming on all the time. So I believe we'll have to have, as you said, another session.
We'll be happy to do it. Thank you for having me.
Yeah. And for the audience, thank you for joining us today. And you will receive a short survey. We would appreciate your cooperation in filling it. And thank you very much, everybody. It was amazing.
Good night, everybody.
Thank you, guys.
Bye.